And now it's my pleasure to introduce Professor Mick Kumwenda. Professor Mick Kumwenda is from England. Is the Director of Renal Services and at Glen Cleveland Hospital and a consultant nephrologist. His research interests include diabetic kidney disease, cognitive dysfunction, and the management of end-stage kidney disease in people with diabetes. You are welcome. The lecture is autoimmune diabetes of type. I think there is something wrong in the title. Yes, it is autoimmune. Yes, it is autoimmune adult type 2 diabetes.
Thank you for the kind introduction, Mr. Chairpersons. Ladies and gentlemen, good morning. So this is my topic for today. And if we start with the historical perspectives, in 1977, there was found that 11% of individuals diagnosed with type 2 diabetes had autoantibodies against insulin-producing beta cells. And the characteristics was similar to type 1 diabetes, indicating there was some autoimmune pathogenicity that they described in that paper. Following that, there was also a description about the UK PDS diagnosed with type 2 diabetes. 84% of these patients who were GADA positive at diagnosis progressed to insulin dependence within six years compared to 14% that were negative for the GADA antibodies. And then in 1993, Kumwenda introduced the term latent autoimmune diabetes of the others to describe a subgroup of patients that seem to share phenotypical features with type 2 diabetes, but immunological features with type 1, and that was published in the Lancet. Several other studies have been done and found that actually in Europe, the prevalence is between 1 to 12%. So characteristically, LADA is a slow onset, low C-peptide, and anti-GADA antibodies positive. So that's kind of takes us well to the rest of the talk. And it's not surprised that the WHO and the ADA classification came out. And typically type 1, as you know, is beta cell destruction and there's absolute insulin deficiency. It's immune-mediated and idiopathic. Idiopathic in quotation marks because, of course, there are some descriptions of environmental factors influencing the development of type 1. And then type 2 is a list of all these. There's the genetic defects. Some of those have been described in a previous lecture, and there's a MODI with 1 to 6 affecting the chromosomal. I've outlined here. There's, some of these are happening in neonatal period, defects in insulin action, gestational disorders, exocrine pancreas. Again, that was described earlier on in the talk, in the session. There's drug-induced infections, endocrinopathies, and common forms of autoimmune-mediated, such as Stiffman syndrome and insulin receptor antibodies. And then there's a well of other rare conditions listed at the bottom. But there's an overlap in this condition between type 1, type 2. Others call it type 1.5, others call it type 3, and then others call it double diabetes. In terms of epidemiology, these are the more recent studies that are listed here, and the main feature was that there's large numbers of patients aged from 15 onwards, and again, the characteristic feature is the GADA antibody positivities, and you can see the frequency of this happening is round about between 2 and 12% described worldwide. So pretty more common than you would have expected, and it's not uncommon that we do miss this condition in clinical practice. This is the pathophysiology. I'll just describe some of the key features about this, and as I've mentioned already, there's characterized by islet cell-specific autoantibody positivity, similar to cell-mediated immune response, although impaired, of beta cell is slower than in classical type 1 diabetes. A recent study showed the presence of insulitis by pancreatic scintigraphy using interleukin-2 labeled technetium and contrast-enhanced magnetic resonance imaging, providing evidence of the presence of activated mononuclear cells in the pancreas of LADA subjects, particularly within 1 year of initiation of insulin. On the right-hand side is a typical pattern. There's one group that has genetic features listed down, and then there's a specific trigger which then causes insulitis and the production of GADA-positive antibodies, leading to complete or near complete insulin deficiency. And then there's another visceral type rather than genetic, that you get a low-grade inflammatory process causing again insulitis and then producing impaired insulin secretion. So those are the two pathways that have been observed in the literature. And then this is just another way of looking at it, comparing the natural history of type 1 diabetes compared to LADA. And you can see here, if you look at pancreatic B-cell mass percentage, you get genetic susceptibility, and then you get a trigger. And you can see the type 1 drop in the pancreatic beta cell mass, followed at a slower rate with the LADA, as you can see, type 1 in blue, and then LADA in the red and the shade of blue, as shown here, with a decline over time, similar to what you see in type 1 diabetes. And there's a significant heterogeneity. It's not just one condition. Some clinical characteristics are different in this group of people, and you can see there on the heterogeneity in light blue as shown on this slide. And this is the pathogenesis that's been described a couple of years ago. The pathogenesis is described as a result of interaction of innate immunity, adaptive immunity, and gut-associated immunity. The macrophages and CD4 cells are the most abundant immune cells infiltrating the pancreas, causing insulitis and the development of LADA. Other immune cells, such as NK cells, neutrophils, CD4 cells, and B cells, were also found to be involved in the development of LADA correspondingly, and you can see here, as demonstrated, the association between gut-associated immunity, innate immunity, and adapted immunity affecting the cells I've just described. And this has led to some attempts in using immunotherapy to reduce the progression of the condition, and this is still in a research setting rather than introduced at a clinical setting. If we look at the linkage of linking immune and metabolic diabetes as published in Diabetes Care in 2018, we can see that they've looked at the genome-wide significant signals associated with LADA, and the studies, quite a large number of studies involving a lot of patients, and the main effects on the chromosome are shown here, and the position of the B37, again shown here. But the more important thing I want to show you is at the end is the frequency of the gene HLA-DB81 and the other ones listed here. But what is shared in most of the studies is the consistency of the HLA-DQB1 HLA-DQB1 in most of the studies. And LADA is in a cases subjects of European ancestry versus population control studies. So you can see here numbers of patients listed here. Both subjects had type 1 and type 2 diabetes. In comparison, LADA to the general population, a novel independent genome-wide significant signal at the locus of PFK FB3 locus. And there was conditioning on the two nearby type 1 diabetes associated signals in chromosome 10p15. So I think this is showing us the genetic linkage with the development of this condition in susceptible subjects and the frequency of some of the HLA, DQB1, and the locus on PFK FB3. Now, in clinical practice, we can characterize the similarities and the differences between type 1 LADA and type 2. And you can, as you know yourselves, that type 1 will come in the childhood period or adolescence, whereas LADA characteristically will be affecting 30 to 50-year-old patients. Subclinical types are rarely acute, and usually initiation of insulin is within 6 months of diagnosis. And the subjects are sometimes obese, but the majority aren't. There's high T-cell islet cell antibodies, decreased but still detectable levels of C-peptide compared to type 1 and type 2. And the family history may be positive, and it's always important to explore the presentation of how some of the family that have developed type 2 diabetes have presented to see if there is a similarity to the LADA presentation. This is a case report that we've seen last year, and this is a 70-year-old female with Turner syndrome, had been diagnosed in primary care as type 2 diabetes in 2015 and was commenced on metformin. Was also diagnosed with hypothyroid in 2019, but presented to the GP just before admission with dizziness, tiredness for 5 days in May 2020. You can see the BMI was 31 glucose was 31.3 millimoles, and ketones were 6.7. When she was admitted to hospital, the pH was 2.5 and bicarbonate was 12.1. And the other parameters showed EGFR 51, cholesterol was high, and ultrasound scan abdomen was normal. Patient was on Lantus, thyroxine, aspirin, and amitriptyline at admission, and the DKA was successfully treated, and the patient was seen by the dietitian and advised how to go about diet. But you can see the C-peptide was less than 50 picomoles per liter. Islet cell antibodies were negative, but the anti-GADI antibodies were 170 mils. At a discharge, patient was on metformin, Novorapid, and atorvastatin. But you can see on the graph here on the right that we had opportunities since 2015, the way there was a fluctuation of the glucose levels showing difficult to control, and the initiation of insulin starting earlier since the diagnosis was made. But this patient could have been picked up earlier if we had thought about the condition in primary care. So this is a typical example that the patient has type 2 diabetes. And this is just a schematic method to look at how we diagnose the condition, as published recently in 2018. So you diagnose diabetes, evaluate age. If the BMI is high, then you suspect type 2 diabetes and start metformin. If you suspect LADA, and then you measure GADA. If negative, then your recommendation will be the same as type 2 diabetes patients. If it's positive, measure C-peptide and start treatment with DPP, so to sensitize the pancreas so they can respond more to insulin. Okay, so how are you doing for time, Mr. Chairperson? We got time. So the therapeutic cartoon that's been recommended by the consensus group recently is that glucose-lowering medications, if you got a C-peptide of 0.3 and less than 0.7 without established atherosclerotic cardiovascular disease, then the treatment should be GLP-1, DDPP, SGLT2, glitazones if possible, and then start basal insulin if the patient does not hit target. And if they have C-peptide, again, more than 0.3, but they have, in those that have less than 0.3, then you can start insulin straight away. Whereas the ones that have got detectable C-peptide, then you can start metformin. And if they got atherosclerosis, then of course, you go the same pathway that you would as recommended by the ADA. So with that in mind, I think this is a condition which we should not be missing in our clinical practice, and it's those patients with a family history and may require insulin soon after diagnosis. And it's very, very important to have in mind that these patients can present later and only picked up because they are requiring insulin at the beginning. Thank you very much for your attention. And
thanks, Professor Mick, for your elegant talk. And we should close this session, and I will interview the other session. تفضل دكتور فريد.
Thank you, Dr. Mick, for your elegant presentation. But I'm not disclosing a secret, but Dr. Mick is a fan of Liverpool and Mo Salah. Do you think it is time for reclassification of diabetes?
yes,
And is the algorithm about the treatment of bladder, is it an expert opinion or is it evidence-based?
Yeah, so this was the group that came up with the algorithm is just a group of experts around the world, and they came up with suggestions of how to manage LADA. The data is not as good as it is for type 2 diabetes as to what we should be using in preference. But the DPP4, so it's the drugs that sensitize the pancreas that should be used first as soon as diagnosis. But initiation of insulin comes very early, soon after diagnosis. So I agree. I think we need proper classification. And I think we need more identification of the cases so we can look at how best to treat them. What is the progression of complications? Do they get more complications compared to other forms of diabetes if they are treated to target? So I agree. We heard about type 3C earlier on in the session. And again, I think these are the types of diabetes that are not described properly at congresses, and it's not much experience. I mean, I can't say I've got a lot of patients myself. We have got some patients with CKD in our clinic, but not so many. And when you look up diabetic kidney disease in LADA, you hardly find very much described in the literature. So I agree. We need more information of this condition to guide us to first of all, identify the patients early, and secondly, to put them on the right treatments that will prevent complications.
Thanks, Professor.
Thank you.